Good afternoon, everyone. Good afternoon.
Good afternoon, sir.
Good afternoon, Krati, Angel. Good afternoon.
Good afternoon, sir.
Yeah. So, how are you all?
Fine, sir. And you?
Good. So, today's topic is muscle energy technique, right? MET. So, what is the importance of MET? Basically, we use MET, that is muscle energy technique. We use it to lengthen a shortened, contractured, or spastic muscle, right? Or we can use it to strengthen a physiologically weakened muscle, right? We can use it to reduce pain. We can use it to stretch tight fascia. MET is also used to reduce localized edema. So, muscle energy technique is used to mobilize an articulation with restricted mobility. We can also use it to improve musculoskeletal functions, and by MET we can improve local circulation. Clear? So these are the uses of muscle energy techniques, right? Indications. Next thing is the guidelines which we have to follow. We should always remember the guidelines. 3 to 5 repetitions for 7 to 10 seconds each, right? Isometric contractions that is required. And we use 20 to 50% of the muscle strength, right? We use isometric contractions should not be too hard. After sustained but light contraction, a momentary pause should occur for 25 seconds, right? And isometric contractions requires forceful contractions. So these are the guidelines which we have to follow during application of MET. Now today we will discuss some key points about modern MET, right? So MET methods all employ the use of patient's own muscular effort in one of a number of ways. So usually in association with the restraining or assisting efforts of the therapist. So therapist and the patient both are the key members during this procedure. The first point is the practitioner or therapist force may exactly match the effort of the patients, so producing an isometric contraction, allowing no movement to occur, and possibly producing as a result a physiological, neurological response, that is a Golgi tendon organs response, involving a combination of reciprocal inhibition of the antagonist of the muscle being contracted as well as post-isometric relaxation of the muscles which are being contracted. Right? So these are the mechanisms which we use, and the other mechanisms are almost certainly involved in the subsequent ability to stretch the tissues more comfortably and efficiently. So, including a possible viscoelastic change in the connective tissues and more probably an increased tolerance to stretching. Clear? So, by isometric contractions, and that will be followed by stretching, we can increase the range or we can stretch the muscle. Right? Next point is the practitioner or therapist force may overcome the effort of the patient, so thus moving the area or joint in the direction opposite to that in which the patient is attempting to move it. This is an isotonic eccentric contraction known when performed rapidly as an isolytic contraction. So a slowly performed isotonic eccentric stretch has the effect of toning the muscle being stressed in this way while inhibiting its antagonist, allowing it to be more easily stressed subsequently. Right? So generally we use isometric contractions, and in some cases we use isotonic contractions. Depends on the force. So practitioner or therapist may partially match the effort of the patient and thus allowing whilst slightly retarding the patient's effort and so producing a toning effect by means of the isotonic concentric isokinetic contractions. Right? There are other variables may be introduced, for example, involving like whether the contraction should commence with the muscle or joint held at the resistance barrier or short of it, a factor decided largely on the basis of the degree of chronicity or acuteness of the tissues involved. So always check the barrier, or it may be anatomical barrier, it may be physiological barrier, right? So you have to record the barrier. How much effort the patient uses, say 20% of the strength or more or less. So research evidence is inconclusive in this topic. So generally we use or patients use 20 to 50% of the total strength of the muscle. And the length of the time the effort is held, that is 7 to 10 seconds or more or less. And this is given by Levitt. So generally we use 7 to 10 seconds, right? And some other scientists like Greenman, Goodrich, they favor 3 to 5 seconds contraction, right? Normally we use 7 to 10 seconds. So whether instead of a single maintained contraction, we use a series of rapid low amplitude contractions, that is Rudy's rhythmic resisted duction method, also known as pulsed muscle energy technique. Clear? So number of times the isometric contraction for its variant is repeated. 3 repetitions are thought to be optimal, right? So 3 to 5 repetitions we can do in case of MET. Next point is the direction in which the effort is made towards the resistance barrier or away from it, thus involving either the antagonist to the muscle or the actual muscles, those are agonists, which require release and subsequent stretching. These variations are also known as direct and indirect approaches. Right? So by using this direct approach and indirect approach, we can give tension to the muscle. So whether to incorporate a held breath and a specific eye movements, respiratory or visual synkinesis to enhance the effects of contractions. So these tactics are desirable if possible. The next point is what sort of resistance is offered to the patient's effort, for example, by the therapist, or we can apply resistance by the gravity, by the patient, or by an immovable object. So whether the patient's effort is masked, overcome, or not masked, a decision is based on the precise needs of the tissues to achieve relaxation, reduction in fibrosis, or tonifying and re-education. Right? Next point, whether to take the muscle or joint to its new barrier following the contraction, or whether or not to stretch the area or muscle beyond the barrier. So this decision is based on the nature of the problem and the conditions and its degree of acuteness or chronicity. Right? Next point is whether any subsequent to a contraction stretch is totally passive, or whether the patient should participate in the movement, the latter being thought by many to be desirable in order to reduce danger of stretch reflex activation. Right? Next thing is whether to utilize MET alone or in a sequence with other modalities such as the positional release methods of strain and counter strain, or the ischemic compression or inhibitory pressure techniques of neuromuscular technique, that is NMT, neuromuscular technique. So we can use MET alone, or we can use in a combination of other things or other techniques. Next point is like Greenman's summarizes the requirement for the successful use of MET in osteopathic situations as control, balance, and localization. So his suggested basic elements of MET include the following, like a patient or active muscle contraction which commences from a controlled position, is in a specific direction towards or away from a restriction barrier, right? So force may be towards or away from the restriction barrier, depends on the condition or depends on the technique we are going to use. So practitioner applies distinct counter force to meet or not meet or to overcome the patient's force, right? Depends on the technique. The degree of effort is controlled sufficient to obtain an effect, but not great enough to induce trauma or difficulty in controlling the effort, right? So what is done subsequent to the contraction may involve any of a number of variables as will be outlined in the topic, right? So essence of MET then is that it uses the energy of the patient and that it may be employed in one or other of the manners described above with any combination of variables depending upon the particular needs of the patient. So Goodrich, one of the first osteopaths to train with Michel, summarizes follows like good results with MET depend on accurate diagnosis, appropriate level of force, and sufficient localization, right? And the poor results are most often caused by inaccurate diagnosis, improperly localized forces, or forces that are too strong, right? So those gives a poor result, right? So now we discuss direct and indirect action. So it is sometimes easier to describe the variations used in MET in terms of whether the practitioner force is the same as or less than or greater than that of the patient, right? So in any given case, there is going to exist a degree of limitation in movement towards end of range in one direction or another, which may involve purely soft tissue components of the area or actual joint restriction, right? So therapist establishes by palpation and by mobility assessments such as motion palpation, ideally involving end feel and the direction of maximum bind or restriction. So this is felt as a definite point of limitation in one or more directions. In many instances, the muscle will be shortened and currently incapable of stretching and relaxing. So to stretch the muscle and to relax the muscle, we use MET. So should the isometric or isotonic contraction which the patient is asked to perform be one in which the contraction of the muscles or movement of the joint is away from the barrier or point of bind. While the therapist is using force in direction which goes towards or through that barrier, then this form of treatment involves which is called a direct action. So should the opposite apply with the patient attempting to take the area or joint or muscles towards the barrier while the practitioner is resisting, then this is called as indirect maneuver, right? Next thing is the variations of MET. So as the most manual therapy approaches, the MET methods employed will vary with the objectives, like relaxation of the soft tissues has the objective of inducing a reduction of tension in contractile structures such as muscles. So relaxation may be all that can usually useful be done using MET during the acute and remodeling phases of soft tissue distress, right? So release of soft tissue shortening is directed towards the non-dynamic connective tissue component of soft tissues, and because such tissues is slow to shorten, it generally requires a lengthy period of applied load, right? And such as is used in myofascial release. So in myofascial release, we apply tension or we apply resistance or pressure for minutes, right? But in case of MET, we apply it for 5 to 7 seconds or up to maximum 10 seconds. So benefit of initially using MET components like isometric contractions to reduce the conditions, like there is an undoubted increase in stretch tolerance following use of MET, which enhances release techniques. So release in the context differs from stretch in that tissues tend to be held against their end of range barriers rather than being forced to those barriers as they are when being stressed, right? Next is Levitt's post-isometric relaxation method. In examination, you can get this Levitt's post-isometric relaxation method that is explained by Levitt. In this, the first point is the hypertonic muscle is taken without force or bounce to a length just short of pain or to the point where resistance to movement is first noted, right? That is the barrier. Second point is the patient gently contracts the affected hypertonic muscle away from the barrier. So the agonist is contracted for between 5 to 10 seconds while the effort is resisted with an exactly equal counter force. So Levitt usually has the patient inhale during this effort. The breathing pattern will be normal during resistance. So this resistance involves the practitioner or therapist holding the contracting muscle in a direction which would stretch it while resistance not being offered. Yeah? So the degree of effort in Levitt's method is minimal, and the patient may be instructed to think in terms of using only 10 to 20% of his available strength. The muscle should not be very hard during the isometric contraction. Patient should use only 20 to 50% of his available strength maximum, so that the maneuver is never allowed to develop into a contest of strength between the therapist and the patient. Right? After the effort, the patient is asked to exhale and to let go completely, and only when this is achieved is the muscle taken to a normal new barrier with all slack removed. Right? But no stretch to the extent that the relaxation of the hypertonic muscles will not allow. So after the effort, the patient is asked to exhale and to let go completely. And starting from this new barrier, the procedure is repeated 2 to 3 times more. Right? So by doing this isometric contractions, stretching, you can gain the range. So in order to facilitate the process, especially where the trunk and the spinal muscles are involved, Levitt usually asks the patient to assist by looking in the direction of the contraction during the contracting phase and in the direction of stretch during the stretching phase of the procedure. Right?
हेलो।
हेलो हेलो चिक हेलो।
क्या हुआ ये
यस।
पॉज हो गया।
पॉज हो गया, सर के में नेटवर्क इशू हुआ शायद। और क्या हो रहा है? ये शक्ल तो
बैठे
दिखा दो।
नहीं भाई, मत देखो।
क्यों? अरे दिखाओ तो।
पागल ना।
अभी कोई नहीं है
सर ने लेफ्ट कर दिया, अभी सर आ रहे हैं। तुम्हारे तुम्हारी भी तुम्हारी भी आवाज।
अब तो हमें तुम बच्चे, अब तो दिखा दो। हाँ दिखाओ, जल्दी दिखाओ। देख मैं आ गई। मैं कह रही हूँ अपनी शक्ल तो दिखा दे माता।